individuals can have cardiovascular or renal morbidity and mortality. So we shouldn't get stuck with a figure. We should really understand why that figure, that is arbitrary, is a guide. And then the above office threshold values correspond to the level of BP at which the benefits of intervention may outweigh inaction. So the reason why this figure was adopted is that epidemiological studies have shown that when individuals have these blood pressures, when you intervene, the benefits of the intervention outweigh the harms of it. I used to ask my residents, what is the basis of this figure for the definition of high blood pressure? And that is it. There are some guidelines which adopt lower cutoffs of 130, 80. But it's been found out that, I think that figure is adopted. It depends on, that's my opinion. I think it depends on how rich you are as a country. When you are richer like the Americans, you adopt lower figures. When you are not so rich like the Europeans, and we are also following them, you keep at 140, 90. But 130, 90, 130, 80 is entertained in some settings. So to the issue of home settings and hospital settings, we need to understand that BPs at home are usually lower than BPs in the hospital. And does the BP definition take this into account? Yes. That's why it specifies that it's office or hospital BP. So that should influence the way we diagnose hypertension in clinical practice using patients' BP recordings at home. It is believed that, and it's actually a fact, that the white coat has effect on hypertension. So it adds a bit to the blood pressure. So the home values are lower. So let me pose this question. A 45-year-old woman has an average BP of 156/94 at a hospital. She uses a sister's fig, which records an average BP of 136/87 millimeters of mercury. The same fig, she brought the same fig to the hospital, and when it's used in the hospital setting, it records the same high figures recorded in the hospital. So the question is, does she really have hypertension? The home figures are lower. Hospital figures, no doubt about it. And if she has hypertension, is this proper hypertension or white coat hypertension? The answer is that this patient really has hypertension, because hypertension, as I said, is defined within the context it is measured. So these are the various definitions for hypertension regarding different contexts. So we've talked about the office BP. We can also measure hypertension using the ambulatory BP device, which is stuck on patients, and they measure BPs from time to time over defined periods, usually 24 hours. And then it averages the daytime and sleep time and the overall BP. With this, daytime BP may be defined as 135 or more, and or 85 or more. And then nighttime, we should note that blood pressure is supposed to dip at night. So at nighttime, ambulatory BP definition for hypertension is 120/70 or more. But when it is put together for ambulatory BP, it is 130/80 or more. But very importantly, for the home BP, it is 135/85 and not 140/90. So we should take note of that. So that patient that we saw earlier actually has hypertension. Now let's look at hypertension, the classification of hypertension. Hypertension may be classified in in two main ways. One is based on the BP figures, the household BP figures, or it can also be classified based on a combination of BP levels and the presence of cardiovascular risk and hypertension-mediated organ dysfunction. Hypertension-mediated organ dysfunction is simply target organ damage, as we would call it. So as far as the classification based on BP is concerned, there is a guideline recommendation, and that's what is in both our guidelines and that of the Europeans. So we have optimal BP, which is less than 120/80. Then we have normal, which is 120 to 129, and or 80 to 140, 84. And then we have high normal. Some people call it pre-hypertension, and that is 130 to 139, and or 85 to 89. Then hypertension is graded into three, grades 1, 2, and 3. For grades 1, systolic blood pressure is 140 to 149, and diastolic 90 to 99. Grade 2, 160 to 179, and or 100 to 109. Grade 3 is 180 and above, and or 110 and above. We also have isolated diastolic hypertension, isolated systolic hypertension, and isolated diastolic hypertension, which use the office figures. We can also classify hypertension by combining the BP class and the patient's cardiovascular risk factors. And based on that, we have stages 1, 2, and 3. Stages 1 cover those with hypertension, but no risk factor, or not more than 3 cardiovascular risk factors. And based on the BP figures they have, they may be categorized as low risk, moderate risk, or high risk. And then we have stage 2, where they have hypertension-mediated organ dysfunction, or stage 3 CKD. Very importantly, patients with type 2 diabetes also fall within these figures, so long as they don't have organ damage. And in this category, based on the class of hypertension, you can categorize their risk as shown. And then stage 3 is when they have established disease like stroke or CKD, stages 4 and 5, or they have diabetes mellitus with organ damage. So this is a very pragmatic way of categorizing BP. The advantage of this is that it takes the patient's cardiovascular risk in entirety together, and it really helps in managing the patient holistically. So diagnosing hypertension, there are a number of things we should take into account. BP measuring protocol. We all know there are protocols for measuring BP. There are studies which show that there are a lot of lapses in the way we measure BP, which contributes to errors in the figures we generate in our hospitals. Repeated BP measurement is very important. We shouldn't rely on a single BP figure. How should we repeat it? Normally, it is recommended that at a sitting, we check the BP about thrice, 1 to 2 minutes apart, and then you take the average. But I think I'll come to the details, so let me skip it for now. And then what is the place of BP, home BP measurement? I'll talk about it. How do you go about home BP measurement? I'll talk about it. And what about ambulatory BP measurement? That's a specific way of measuring BP with a device, as I said, that measures BP periodically over a defined period of time. We need to confirm BP because we need to confirm hypertension initially because BP varies for the same patient. It varies depending on the setting depending on the time of the day and depending on the person's situation. Some people, when they are broke, their BPs go up. Others, when they are broke, their BPs come down. It depends on the individual. My BP is not affected by my financial status. It's always normal. So home BP measurement and ambulatory, in the confirmation of diagnosis, guidelines recommend that home BP measurement and ambulatory BP measurements should be used to confirm hypertension whenever possible. So there is a place for asking patients who have the means to measure their BPs at home, and we'll learn how this is done. BP measuring devices are very important. Currently, the automated cuff-based BP measurement is what is recommended by guidelines. And that's what we mostly use in our facilities. Then mercury-free or auscultate-free, the aneroid sphix are also recommended. Mercury sphix, as we know, have been banned from clinical practice for obvious reasons. And when BP cannot be measured by an upper arm cuff device, a validated electronic wrist cuff device may be used. We have some of these devices around. They are also recommended. Now we have cuffless BP measuring devices. There are even apps on phones which are able to tell people their BPs. Currently, even though guidelines acknowledge that some of them are quite reliable, they are not recommended for various reasons, because many of them have not really been standardized. So as of now, guidelines do not recommend cuffless BP devices. Some of these devices, you put your finger on something and they tell you what your figure is. They can only be used in conjunction with the cuffed BP devices. So standardization of office BP measurement is very important. There was a systematic study, review that involved over 300 articles that identified about 29 potential sources of inaccuracies related to the patient, the device, the procedure, the observer, which may contribute to inaccuracies in the BP figures generated. So it's of utmost importance to use standardized office BP measurement methodology that allows uniformity of the setting and the conditions of measurement. The patient position, very important, the device itself, the measurement schedule, and then the interpretation of the results. Now, based on these standardized procedures, office BP should be measured on the bed. Sometimes patients come with long sleeves, and we see our nurses are putting the cuff on the sleeves. It is not recommended. It should be on bare arm. Of course, we know that one size cuff does not fit all, so appropriate cuff size should be used as much as possible. Now, the problem with cuff size is that a smaller cuff overestimates, whereas a larger one underestimates. Sometimes you see a very tiny person with the normal cuff on his or her arm. Sometimes you can't even see the arm after the cuff has been applied. So we need to use appropriate cuff sizes for our patients. So there are dimensions for the various cuff sizes. I won't go into it. So let me just look at this diagram that I took from the European guidelines. Gives us some of the things to consider in standardization of the BP measurements. It's recommended that we use validated devices. The room should be comfortable with, it should be quiet with a comfortable temperature. Patients shouldn't have smoked, used caffeine, or done an exercise 30 minutes before the measurement. The patient should be seated and relaxed for 3 to 5 minutes. Quite often, as soon as patients get into the hospital, the nurses literally bangle them into the chairs and measure their BPs. For home BPs, it is recommended that at any given time, patients take 2 readings, 1 minute interval between them, and then they record the average. At the office, 3 readings are taken, 1 minute interval between them, and we use the average of the last two. So at any given time, measure 3, average the last 2. The bare arm on a resting table and at the heart level, the legs should not be crossed. That's what I mean. I don't understand how crossing your legs can affect your BP. And then patients should sit backward with their backs. They should sit with their backs supported. So there are several sources of inaccuracies. So I think I'll skip this slide. For home BP measurement, very important. According to the European guidelines, it may be more reproducible than the office BP. And practically, it has been found to predict target organ damage and CVD, morbidity and mortality better than office BP. And it increases, it's more associated with increased predictive ability for outcomes. It helps to measure day-to-day variability, and day-to-day variability is known to correlate with adverse prognosis. And it helps to identify various hypertension phenotypes, such as masked hypertension or white coat hypertension. And very importantly, home BP measurement may improve adherence to treatment and thereby favoring BP control. Now, the figures are different for office BP or hospital BP. As I said, for the definition of hypertension, the figure we use is 135/85 and above. And when it comes to management, very importantly, the recommended target for management using home BPs is less than 130/80. When we go into the targets, realize that this is actually the same even for office BP measurement. How should we advise patients on how to record their BP at home? The home BP should be monitored for 7 days and never for less than 3 days. So we should advise patients that when they should, maybe prior to the visit, they should monitor their BPs for 7 days, but not less than 3 days. And they should do it in the morning before they take their drugs and in the evening. And at any given time, they should measure their BP twice and take the average. I wonder patients who have forgotten their math and can't do averages. Maybe they should just record it, and when they come, you look at the averages yourself. So clinical indications for home BP management, patients with grade 1 hypertension on office BP. So if a patient's BP is 140, 159, 90 to 100, it helps to do home BP to ascertain the diagnosis. And for patients with conditions like masked hypertension, very importantly, for example, somebody comes to, somebody does ECG and the person has left ventricular hypertrophy, BP is normal in the hospital. You may ask the patient to do the BPs at home. The person may have masked hypertension. Masked hypertension is a situation where BP is normal in the hospital setting, but may be higher at home, or may be higher at home. It also helps in the confirmation of patients with hypertension, resistant hypertension, and the other benefits of that. Now let's talk about the management of hypertension. But hypertension management should be patient-centered. It should be individualized and goal-oriented. Very importantly, the management of hypertension is not just about dishing drugs to patients, as we quite often do, but it should be patient-centered. It should be individualized, looking at the patient's, socioeconomic status, the patient's level of understanding, the patient's age, other comorbidities, etc. It should be goal-oriented. We should look at goals are different from targets. I'll go into it. And management should focus on preventing hypertension-mediated organ damage or cardiovascular events. Now, the good thing is that even BP reduction of as little as 7 millimeters of mercury substantially reduces major cardiovascular events like stroke, MI, heart failure, etc. So this is quite refreshing, especially in cases when we are not able to achieve our targets. Even if we're able to reduce it a bit by so much, it helps. BP reduction reduces kidney damage, cognitive decline, and dementia. Now, what should be the goals of BP management? When we are managing BP, we should always discuss goals with patients. And what are these goals? So I'll give you these 7 goals. 1, our goal should be to reduce cardiovascular risk to the barest minimum, to prevent the incidence and progression of target organ damage involving the heart, blood vessels, kidney, brain, and eyes. Number 3, to achieve targets of cardiovascular risk and comorbidities. Example, we should achieve target BP, LDL cholesterol, HbA1c, body mass index. Another goal is to achieve lifestyle modification, including physical activity, diet modification, and then to optimize quality of life, empower patients through education, and then prevent complications and premature death. Premature death is defined as death before age 70. So how do we achieve this? First, we have to work up the patient through a thorough history, physical examination, and investigations. And this will help us to assess for the presence or otherwise of target organ damage or hypertension-mediated organ damage, as some call it. Very importantly, we have to assess the patient's cardiovascular risk. The patient's cardiovascular risk refers to the risk of he or she having a cardiovascular event such as myocardial infarction or stroke in the next 10 years or so. Then we have to stratify the patient based on the patient's BP, target organ damage, and cardiovascular risk. And the chart I presented earlier is very useful in that regard. Patient education aimed at empowering the patient for involvement in his or her management, very important. Goal setting. Every patient should understand the goals and why the goals. We should discuss the goals with them, and especially those who can read, we should document it for them. And then targets. Targets for blood pressure and other CVD risks should be documented and discussed with the patients. Lifestyle interventions, very important, and then pharmacotherapy. Investigations, we all know what to do: full blood counts, urinalysis, blood glucose, BUN and creatinine, including eGFR, albumin-creatinine ratio, very important for as part of assessment of kidney function, serum lipids, uric acid, chest X-ray, and then a 12-lead ECG. Echocardiogram is not mandated in every case of hypertension. I'm sure Dr. Nani will talk about that, so I'll leave it for me. Very importantly, we need to assess the cardiovascular risk of patients. So this chart is very important. I won't go into details. It's very much in the cardiovascular guidelines. So we should learn how to use this diagram, this chart, the WHO chart for risk stratifying patients. So now let's go into the specifics of management. It depends on the patient's risk category or where the patient is. But management involves lifestyle intervention and then pharmacotherapy. So I'll go into the lifestyle intervention. What lifestyle interventions are currently recommended. Number one is weight reduction. In our standard treatment guidelines, it is recommended that patients who are obese should lose 12% of body weight in 6 months. And that it tends to be practical for me. Restriction of sodium intake, very important. 5 grams, less than 5 grams of salt per day, or 2 grams of sodium per day is recommended. Augmentation of dietary potassium. The potassium has been found to reduce blood pressure, and not only blood pressure, but cardiovascular risks and deaths. So 3,500 milligrams per day is recommended. And the sources of potassium include potassium chloride tablets, which is normally indicated for people with low potassium. But otherwise, dietary sources are very good. And they include fruits, vegetables, low-fat dairy products, nuts, soy products, fish, and some meat. Increased levels of physical activity, we all know. What is recommended, as we know, is a minimum of 150 minutes of moderate intensity aerobic exercise. If it is high intensity, 75 minutes is okay. But it's been found out that for people who are sedentary, 6 minutes of physical activity per hour is very beneficial. So even a little exercise helps. Still on lifestyle intervention, moderation of alcohol intake is very important. It reduces blood pressure and cardiovascular diseases. Smoking cessation, very important. And then dietary interventions, the best is the DASH diet and also the Mediterranean diet, which emphasize whole grain, fruits, vegetables, low-fat dairy products. Stress management, the stress in the system is not easy. There's evidence to show that various stress management interventions help a lot. Then exposure, minimizing exposure to noise and air pollution. This is quite hard for individuals to achieve, but it is found to reduce blood pressure and cardiovascular events. Now let's talk about antihypertensive treatment. Most patients with hypertension require antihypertensive treatment alongside lifestyle intervention. And pharmacotherapy should be selected to achieve BP control, prevent incidence and progression of target organ damage or hypertension-mediated organ damage, and minimize CVD risk while avoiding potential side effects. In considering pharmacotherapy, what do we look at? The stage of the hypertension, the presence or otherwise of hypertension-mediated organ damage or target organ damage, the patient risk for side effects, especially, for example, if you are looking at a childbearing women, you should be careful about drugs that can affect the fetus, like ACE inhibitors and ARBs. Generally, combination pills are preferred as they improve adherence. So what are the specifics? From our national guidelines, grade 1 hypertension is supposed to be treated first of all with lifestyle and observed for 3 months. And if after 3 months, patient does not achieve targets, then we start pharmacotherapy. But right from the beginning, for patients with stage grade 1 hypertension, if they have 3 of the listed risk factors, they ought to start pharmacotherapy right from the beginning. So male, men more than 55, women more than 65, the person smokes, is obese, has dyslipidemia, impaired fasting glucose, family history of early CAD death. If they have 3 or more of these factors, right from the beginning, they should start pharmacotherapy. For grade 1, we can do monotherapy, even though the European guidelines currently recommend dual therapy right from the beginning. So you start, the options for us is thiazide-like diuretic or calcium channel blockers. So you start it and review in 2 to 4 weeks. If the target is not achieved, then you introduce the second drug. So the second drug, there are a number of options. You can combine any of these calcium channel blockers or thiazide-like diuretics, you can also add an ACE inhibitor or ARB. For grade 2, what is recommended is dual therapy right from the beginning. And any of the drugs can work: calcium channel blockers, thiazide-like diuretic, or ACE inhibitors. So you start with 2 and observe for 2 to 4 weeks. If target is not achieved, you add a third drug, and so on. For grade 3 hypertension, you also start with dual therapy. And then if response is not adequate within 2 to 3 weeks, you can add a third drug, just like for grade 2. What are the BP targets? Now, currently, the safe BP target is less than 130/80. But the first BP target to achieve is less than 140/90. Then when that is achieved, you work towards less than 130/80 for most patients. Now, BP target is also modified by the presence of target organ damage. So to make it simple, for patients with target organ damage, it is recommended that we target less than 130/80. I'll not go into the details of target organ damage because Dr. Nani will do that. But the above are the recommendations in our national guidelines. But the ESH categorizes, recognizes various age groups and what they can tolerate. So for younger people, less than 65, it is recommended that you achieve a target of less than 130/80. For those 65 to 90, less than 80, the primary goal should be less than 140/80. Let's know that it's 80 and not 90. But if the person can tolerate less than 130/80, that is even better. For people 80 and above, we can aim for systolic blood pressure of 140/150 and 130/139 if they can tolerate it. Now, there are cautions in the management of hypertension. We should gradually reduce BP over several weeks and not be aggressive. Where we are likely to violate this is when patients come with very high blood pressures, which we call hypertensive urgencies. Hypertensive urgencies don't need drastic BP reduction. We have to avoid rapidly reducing BP in such patients because they risk worsening target organ damage. And then the guideline says we should not aim to reduce BP to less than 120/70. But here the level of evidence is C. And I captured the level of evidence because currently there are systematic reviews, very solid, which show that what is called intensive targets, which are less than targets less than 120/70 are very beneficial and safe, even in older patients. So whilst the guidelines capture this, we need to recognize that there are systematic reviews which suggest that patients can tolerate lower BPs, just that we may not necessarily aim to achieve them. In patients with isolated systolic hypertension in whom the BP is less than 70, now they've told us not to reduce BP to less than 70, but especially older people, they have lower diastolic blood pressures. So if the patient has isolated systolic blood pressure, but the diastolic blood pressure is less than 70, what do you do? The recommendation is that ignore the diastolic blood pressure and focus on your systolic blood pressure. So in summary, There are lots of things I could have added to the summary, but we should adopt standard protocols in diagnosing hypertension. Repeated BP measurement combined with home BP measurement is recommended for confirmation. Patients must be evaluated comprehensively to assess for the presence of target organ damage and then cardiovascular risk, and then manage patients in the context of those. Management should be goal-oriented, aimed at reducing cardiovascular risks and deaths. Thank you very much. So my main references are from the national guidelines and the European guidelines. Thank you.
Take note of. I'm sure you're asking yourself whether you've been measuring the BPs well, or whether your nursing staff is measuring your BPs well. We need to be able to teach them so that we can be sure of the BPs that we are getting. Are you diagnosing well as well? Remember that the office BPs and the home BPs are slightly different when it comes to diagnosis. Are you setting your goals and are you setting your targets? A lot of time we just start medications without coming to a common grounds. And in common grounds, we are setting goals and we are setting targets. I think it's well said about that. A lot of times we don't even take our clients through the lifestyle modification. And I think that he made mention and elaborated on that every patient who comes to you with hypertension, we need to take them to lifestyle modification. The pharmacotherapy is only an addition to the lifestyle modification. And I've already seen somebody putting in that, Dr. Stoddard didn't touch on resistant hypertension because people are having challenges with that. So Dr. Stoddard, I'm thinking it will come back as a question. So please be ready for our question. I think our next presentation is going to be done by another good friend of mine, Dr. Seth Nani. He's a senior physician specialist and a cardiologist with West Municipal Hospital. He's a of the Ghana College of Physicians. He's also a contributor to the National Cardiovascular Guidelines and also a team member for the CVD Guidelines Focused Update. He's also a trainer with the Ghana Heart Initiative Program and has interest in preventive and interventional cardiology. My very good friend, Dr. Seth Nani, will be taking us through the second presentation on review and assessment of common complications of hypertension in primary care. Review and assessment of common complications of hypertension in primary care. Before he takes over, I just want everybody to know that this CPD is kindly sponsored by Symbiotica. That is former Sanofi and Pharmasymbiosis. I think they've combined and they are now Symbiotica. And we are grateful to them for always being a partner in these programs. Dr. Seth Nani, your audience.
Thank you, Tia, and thank you so much, Justice Dazi. And I'm happy to be here. We've learned a lot from what Dr. Dazi actually went, and I believe we are going to learn something. What I'm going to share really may not, so it will be just a revision for most of us. I believe it will help us in the care we give to. So I'm set as I was introduced, and then I'll be taking you through the review and as common complications of hypertension in primary care. And as Dr. Stoldazi said, it really is the engine of our healthcare. If we are not able to get it right, if we are not able to get it right at the primary, then we are going to end up having a lot of problems. But a number of specialists currently at the primary care, all levels of care, and they are helping deliver good care. So I know part of the country is sick. So my outline is simple. We'll have a background presentation, and then we'll look at hypertension and end organ damage. But I'm going to refer mostly as complications, so that, I mean, it speaks to the, and then we're going to also look at the management of complication of hypertension. So for the background, I'll just go through the burden of the complications of hypertension. And this is actually going to be data from Ghana, not around the world. So we'll start from around the world, and then we'll look at the data in Ghana, because we practice in this part of the world. And we need to know what is going on so that we can help cater for the health of our citizens. So worldwide, among the cardiovascular death, or the death around the world, we have about 17 million due to cardiovascular problems. And the complication of hypertension actually accounts for more than half of this death worldwide. And we also know that hypertension is an important risk factor for coronary heart disease, congestive heart failure, ischemic and hemorrhagic stroke, renal failure. And I'm going to refer to all these as cardiovascular events whilst I go through the presentation. And Prof. Owusu from Komfanochi Teaching Hospital also documented that in their clinic, hypertensive heart disease is the commonest cause of the main cardiovascular diseases in their clinic. And if you look at Ghana, the recent article by Doku et al., which was a systematic review, showed that the highest risk factors for cardiovascular diseases in Ghana were hypertension and diabetes. And also Aban et al. Right here in Ghana also made us aware that hypertension is the top killer and the main cause of admission, with 65% contribution to all death in Korle Bu Teaching Hospital. What we need to understand is that there's a continuous association between blood pressure and the relative risks for cardiovascular endpoint. I mean, heart failure, coronary artery disease, stroke, and peripheral arterial disease. We also look at more statistics in Ghana. And heart failure basically has also, when you look at heart failure in Ghana, Majekom et al. In Korle Bu Teaching Hospital, Owusu et al. In Komfanochi, actually found out that hypertension is the most commonest cause or risk factor. When you look at stroke, the largest stroke study in Africa, Ghana, Nigeria, called the Siren study, also showed that hypertension actually is the commonest risk factor or cause. And all the complications we are referring to are end product of hypertension. The Ghana Renal Registry, published by Boima et al., also tells us that hypertension is the commonest cause of kidney failure in Ghana. But globally, it seems to be the second to diabetes. But Ghana has hypertension actually being the first. So this tells us that hypertension is really driving a big problem in Ghana. J. Lee et al. With some local artists also found out that the carotid intima thickening, which is actually a predictor of cardiovascular events and left ventricular hypertrophy, actually have hypertension as their commonest risk factor and cause. So from all that we have been saying, we see hypertension as the main driver of the complications in in the cardiovascular disease space. And what's the impact of this complication? I mean, if you look at a condition like CKD, which we've looked at and seen that hypertension actually is the commonest cause. We have an article also in Ghana, Hanoi et al. Also found out that it is not just the health or the physical ailment, it's also the quality of life. And they found out that patients with moderate to advanced CKD had low income status and also had a poor quality of life. And having a low income status, as made reference to, alone, without having any disease condition, even makes your life, it actually gives you a poor quality of life. Even if you're a salary worker, at times when the beam balance goes towards the negative or the other side, the quality of life seems some way. And adding complications to it basically makes it worse for the patient. And then Gano et al. Also showed that the psychological status and well-being of these patients are not the best. So they found out that the depressive symptoms were common among patients in long-term dialysis. So if you look at the diagram there, it may not show clearly, but the quality of life is talking about the physical status and functional abilities, the social interactions. If you have heart failure, your legs are swollen, you walk a little bit and you get tired, you can't really have that social interaction. Religious and spiritual status, going to church sometimes, walking to the bus stop, boarding a car, you have heart failure, is not easy at all. It even impacts on your ability to rise spiritually. And economically as well, we've seen it. And the psychological status, we've spoken about it. One of the main impact is in the income and the finances of these patients. When you look at dialysis, effective dialysis 3 times a week, and I hear it's about $380 per session, and you are doing this 3 times a week with your drugs, you must earn a lot to be able to cope with these. And if you also look at the cost of medication, heart failure, the new drugs on the block, SGLT2 inhibitors, talking about empagliflozin, dapagliflozin, costing around $600 to $1,500, depending on where in Accra you actually buy the drugs. And then the cost of procedures, if you have a heart failure now, the reperfusion strategies for ST elevation and high risk non-ST elevation, so expensive. Just angiogram is around $1,500 to $1,750. Opening a segment of just an artery that is blocked, like $2,000 per stent. So the cost is huge. The caregivers are not left out. Depression, anxiety, especially among the females, because the men will run away and say they are going to work and they will leave the women to take care of those who are not well. The impact on dependence and life expectancy, all these are affected. Why all these in the introduction? I put all these in because it brings to the fore the magnitude of the problem. Sometimes hypertension is seen as a normal condition, even with a name essential, as if you should get it when you are. So when you get it, it's essential. So we are treating something essential. But that's not the case at all. If you look at what's a paper by Sanoade et al., they found out that the prevalence of hypertension was around 59% in Ghana. 19% were aware, and these are very huge numbers. Around 68% of those who are aware were on treatment, and about 12% who were on treatment had their hypertension controlled. That means a large number of people are going to end up having the complication. And most importantly, we are the force of the change in this course of affairs. Wherever we are the ones that can pick these complications up. We are the ones that can actually educate the populace about the impact of hypertension. So how can we change the narrative? Advocacy and online and here, some people are part of national decision-making ministries, organizations. We can educate the public opportunistically or intentionally with a hospital base, the media, social print, airwaves, and then mass screening, going to churches and social gatherings and our workplaces. And also early recognition and prompt management of hypertension. And then we can intentionally assess for complications in hypertensive patients. But sometimes the numbers are too many at the clinic. Some people say, let's clear them very fast. Let's clear them very fast. But in clearing hypertensive patients, you are clearing complications and you are not looking at it. And so if you take our time and we are a little bit intentional within the short duration, we can pick up quite a number of complications and help these patients. So what are these complications? So hypertension really is not a problem of the vessels alone. Wherever the vessels go, the complication can arise. And the eyes, the heart, hypertensive heart disease, brain, the kidney, the vessels themselves, and then sexual dysfunction, which is a serious matter, very serious matter. And we'll look at that one as well. So we'll start with hypertension and the eye. As they say, the eye is the window to the soul. So we'll look through the eye and see first. So chronic hypertension progressively damages the retina, causing few symptoms or no symptoms at all. So patients may not report. So it's incumbent on us during encounters with the patient to ask them, do you have blurred vision, any problem with your sight? And that can help pick up subtle changes that they are having so that we can refer them. Pathophysiologically, arteriosclerosis is the underlying problem. The walls are becoming hardened, thickened, and then there's also atherosclerotic process going on. And then we have the changes as they present clinically. Acutely, we can present with malignant hypertension and also have all these retinal changes, hemorrhages, cotton wool spots, which are ischemic spots, yellow hard exudates, lipid spots as well, and optic disc edema, telling us that these patients have papilledema. Diagnosis will basically come from the history, duration, severity of the hypertension. And if you can, in the clinic, you can do fundoscopy. But if you can't, you can just refer. And in most hospitals now, Ghana Health Service, the tertiary centers, they have quite good eye centers and they can help out. Treatment basically is not, it's just controlling the blood pressure, and also you refer for the ophthalmologist review. If you can actually see the patient and do the fundoscopy yourself, you can grade the retinopathy. Grade 1, grade 2, basically showing mild generalized retinal vessel narrowing as well as focal narrowings and AV nipping. Grade 3 and grade 4 are really severe, and these grades 3 and 4 actually predict cardiovascular events. So if you start seeing exudates, cotton wool spots, and papilledema, they predict cardiovascular events like stroke, tension, and changing on the screen. So if you look up there, I actually put up a picture for us to look at some of the changes. Now, I hope you can see the AV nicking or nipping, exudates, the cotton wool spots, papilledema. It's a bit blurred, but maybe after the presentation, we can take some time off and look at the picture on the internet. Hypertension and the brain. Hypertension is a risk factor for acute CV events. Chronic, sometimes they are chronic, asymptomatic, or just few symptoms emanating from the brain damage. Acutely, they can present as hypertensive encephalopathy, ischemic stroke, intracranial hemorrhages, TIA, and subarachnoid hemorrhages as well. Chronically, small vessel ischemic disease, cognitive impairment, and dementia, which have all been documented as complications of diabetes. For the pathophysiology, we know the underlying problem is atherosclerosis with a medial hypertrophy. Lumen of the vessels are narrowing, endothelial dysfunction, decreased nitric oxide production, impaired relaxation of the arteries. And these patients actually come with all the clinical presentation based on what is going on and at the vessel level. Presentation, So if you are in the clinic and you see a patient who comes in with a history of hypertension, sudden onset of limb weakness, maybe one side, speech disturbance, difficulty in swallowing, visual disturbances and seizures, fecal, sometimes urinary incontinence, you should be thinking about stroke. And then also patients who come in with duration less than 24 hours with no tissue or any lesion on imaging, then you can call it TIA. When patients come with severe headache, nausea, vomiting, neurologic signs, sometimes stupor, coma, then hypertensive encephalopathy, subarachnoid hemorrhage may be what you should be suspect. Chronically, forgetfulness, cognitive decline of all degrees should tell you that the hypertension is actually affecting the memory of the patient, and such patient may be presenting with dementia. How do we screen these people? CT scan and brain MRI, especially when they come acutely. So the radiologist will comment, or if you can read it yourself, cerebral infarct hemorrhages will tell you there's a stroke. If there's no tissue abnormality and symptoms resolve in 24 hours, then you are dealing with TIA. Blood in the subarachnoid space, then you are dealing with subarachnoid hemorrhage. Edema in the cortex, subcortical white matter, hypertensive encephalopathy. The good thing is that you don't have to be reading it yourself. Somebody, when you send it, they are radiologists trained as specialists, so they will give it to you. But sometimes you as a clinician will have to marry what they are saying at the clinical presentation of the patient. There's sometimes that you get a report, you look at the patient and you say that, no, this one, even though I'm not a specialist, I will call and find out. It's also not the fault of the radiologist. Sometimes what we write on the request form is so scanty that they are not able to actually give us what we need. And it's as it is said, garbage in, garbage out, and you take your garbage like that. But you don't take it like that. You can actually go back to the radiologist and discuss that this is actually what I was thinking about, and everything can be streamlined. For microinfarcts, microbleeds, things that really do not come acutely over time, they cause dementia and memory impairment as well. We cannot do CT scan and MRI for every hypertensive patient. So it's important that at the clinic, we have tools that we can use to assess this patient. So the cognitive screening tests are there, the mini mental state, you can just print it out. And also the newer Montreal cognitive assessment tool is also there. And if the score for MMSE is below 24 or below 26 for the Montreal tool, it tells you that, and patient also has subjective complaints. It tells you that there's a problem and you need to refer this patient to see the neurologist. I mean, for our side in our practice, primary care, what can we do? We control the blood pressure. We know that hypertension increases stroke rates by 3 to 5-fold, and three-quarters of all strokes are incident events. Hence, primary prevention is essential. Most of the strokes we see are first-time strokes, and so dealing with them at the primary level is key to prevent the recurrence and further damage to the brain. And also, you can institute a guideline management strategies for stroke, TIA, and hypertensive encephalopathy. And we can't go into details of stroke management, TIA. They can also take hours by themselves, but they are guideline management and we can follow that protocol. Lifestyle management is very important. Secondary prevention is key, especially in patients who have ischemic strokes. Antihypertensives should be given, antiplatelets should be given, high dose statins. Because I mean, I'm still in the periphery, primary care, and we see a lot of stroke patients in the periphery. It's not just the referral centers, and sometimes you see patients who have had ischemic stroke on 20 milligrams atorvastatin, 10 milligrams rosuvastatin, and by and large, these doses are not going to do the work that they are supposed to do. We also need to control other risk factors. Importantly, TIA we should have a strategy of dealing with them. Hypertensive encephalopathy is an emergency, so it should be managed as such. Subarachnoid hemorrhage, we control BP, we prevent cerebral spasms so that delayed ischemia doesn't happen. Adequate hydration, analgesic, and prevent intra-abdominal pressure by giving lactulose and also allowing so that the person doesn't strain and cause further rupture of any aneurysm that will be present. The key points here in stroke management, I just want to bring this, even though, wow, my is very small, but I hope you can see acute stroke, hemorrhagic stroke. For hemorrhagic stroke, is also an emergency, and the plan is actually to try and lower the BP to less than 140/90. Unlike ischemic stroke, for ischemic stroke, if the BPs are not more than 220 or 120, there is no need to crash it because there is a compensatory mechanism within the first 24 to 48 hours. Somehow the BP is able to come down. So if you crash it, you are going to increase the ischemic area and rather increase the defect or the neurological problems that this patient will be bringing. Key on this slide is the fact that if you see a patient and because of our practice and over the years, we are used to just giving drugs. But standard treatment, there are some patients that may qualify for IV thrombolysis. And if patient presents with ischemic stroke and is within the 4.5 hours window, please, we have the stroke unit. You can call them. And if they can thrombolyze the patient, we send the patient over and it is done within the window of 4.5. We should not be used to the just give the drugs. Is he well? He's well. Is he moving his hands? He's moving his hands. No, please. There are ways and then guidelines that directed treatment that we should actually follow. TIA. Let's refrain from telling the patients that, oh, don't worry, it's a minor stroke, or oh, don't worry, the symptoms are gone. You are fine. Patient is not fine. And the underlying problem is still at play. TIA, if untreated, carries a high risk of early stroke and is associated with poor survival. So essential things to do: image the brain and make sure that there are no tissue lesions like stroke, infarct or hemorrhages. And then the patient also has a resolution of the symptoms within 24 hours. And we need to score the patient using the ABCD score because you are the primary center. This patient comes to you. You've seen this patient. What are you going to do? Is the patient going to go home and come back to see you later? Or are you going to admit? The ABCD score will actually help you to actually age, and it tells you diabetes, speech, and all that will help you actually to determine what to do for the patient. And this slide will tell you that if you have a patient, among all the other things you do, determine the ABCD score. If it's 4 or more, this patient needs to be admitted. If it's less and patient is fine and there are no other problem, you can consider OPD management. And then also for minor strokes, you can now give dual antiplatelets. And then, and it's been found out that outcomes are better with dual antiplatelets. That's aspirin and clopidogrel. And if you are going to do that, for how long? For 3 weeks, you can give the dual antiplatelet for those who have high risk transient ischemic attack or minor ischemic stroke. And then you can stop the aspirin and continue with the clopidogrel for long-term duration. How about hypertension and the heart? There's a term we use, and I don't know, most people have seen it. Anytime you send patient for an echo and they're hypertensive, there's likely either is left diastolic dysfunction or hypertensive heart disease. Hypertensive heart disease is actually a constellation of findings. So we have left ventricular hypertrophy in there, left atrial enlargement in there, atrial arrhythmias in there. Even vascular problems are part of this constellation called hypertensive heart disease. For LVH, it's just a compensatory mechanism. The heart is pumping under high pressures. The afterload is high. So what it just builds up more muscle to be able to push the blood. But it's been found out that this LVH is actually a predictor of heart failure, sudden death, and it's associated with cardiac arrhythmias. And if these patients are not, if the LVH is not dealt with, going down the line in some years, this patient might come down with heart failure. And it's also a predictor of all-cause mortality. How about left atrial dilatation? It's actually associated with both the duration of the BP and the level of the systolic blood pressure. And this is a back pressure effect. When you have hypertrophy and the intraventricular pressures are high, I mean, it's a continuum. So the back pressure is sent to the left atrial. And because of its wall thickness and its nature, it undergoes structural remodeling because of the pressure, electrical remodeling as well. And it may become big or become arrhythmogenic. And then it's also been found now that treatment of hypertension is actually linked with reduction in the atrial enlargement. I will speak about the degrees of hypertensive heart disease. So normally when you ask for the echo, you see left ventricular diastolic dysfunction. That's first degree or degree 1 hypertensive heart disease, referring to LVH. And this is the initial presentation of this patient. Going further, if nothing is done, BP is not controlled well, hypertrophy will come in, and this is the time that the patient can go on to the 3rd degree and have heart failure with preserved ejection fraction. So the EF is fine, but the heart is failing. Some people call it diastolic failure. So the pressures are building, the left atrial pressure goes up, it goes back into the lungs, and there's a buildup, there's pulmonary edema, and these patients are in failure. The worst you don't want to have is the advanced stage of stage 4. The heart beats with the muscles over time. The muscles get tired, fibrosis sets in, and so it gives up. And from that thick muscle, it becomes very thin. And the ventricle size actually balloons out. The ability of the muscles to contract goes down. And so the ejection fraction is low. So that's when we call it heart failure with reduced ejection fraction. And this is the point where patients are going to pay more money to keep themselves alive, because the standard drugs to be used are very expensive, as we've spoken about. And these are pictures actually telling us, when you look at the top echo views, the parasternal long axis and short axis, you realize that the left ventricle is meaty. It looks like this is enough meat. That means the walls are hypertrophied, concentric. When you look down there, the ventricle is actually big now, walls are thin, and it's not able to contract well. And that's what gives the dilated cardiomyopathy. And so that's the progression. Looking at the side, the schema at the side, normal, then it goes through concentric, hypertrophy, and eccentric. You don't always have to go through concentric. You can move from the normal and have eccentric right from there. So there's a need to keep the blood pressure, because this end organ damage complications actually have severe or dire consequences for the patient. Radium abnormalities, especially from dilatation of the left atrium, or even if the left atrium is not dilated, the high pressures, the fibrosis actually makes the heart irritable, and atrial fibrillation is common. And the mechanism is through myocardial ischemia, fibrosis, the enlargement, the thickness of the muscles we've spoken about, oxidative stress, the catecholamines being released. All these actually push for arrhythmogenicity in this patient. Coronary artery disease, we know about it, acute coronary syndrome, and also chronic coronary syndrome. Heart failure, hypertension is known to increase the risk of heart failure twofold in men and 3 times in women. 68% of elderly patients with heart failure actually have hypertension as the underlying cause. The aorta can also be dilated in hypertension. So sometimes you ask for an echo and we'll say that there's hypertensive heart disease and the proximal aorta or aortic root is also dilated. And this is actually studied. And if you have proximal aortic dilatation in patients with hypertension, it's a predictor of aortic aneurysm and dissection or rupture. And it also tells you that there are other hypertensive target organs and problems going on if you see this. And so sometimes we may write that the aorta is dilated at the root and also ascending part, and it may be due to hypertension. You don't just leave it there. You go on and investigate, because if there are sometimes that they develop aneurysms, and if you don't do a CT scan to look at the extent of this dilatation and possible aneurysm, you may end up leaving a patient who is at risk of rupture, and it will not be dealt with accordingly. What's the evidence? We have so much evidence to that effect that high BPs are related to aortic root dilatation. And I put these 3 studies, and this is just to tell us that it's not just something we think about, but studies have actually confirmed that. Clinical presentation of this hypertensive heart disease in the clinic, usually left ventricular hypertrophy is usually asymptomatic. We pick it up on the ECG, and then we ask for an echocardiogram. Sometimes this patient, because of the ventricular hypertrophy, may have perfusion, like demand-supply mismatch, and can get ischemic chest pain. As for beats due to atrial contraction, and then if you put your hand at the apex, you have a heaving apex. Left atrial dilatation, basically they will come with symptoms of arrhythmias, palpitation, stroke, dizziness, syncope, and even cardiac death sometimes. But the most common thing we pick up is the irregular pulse. Coronary artery disease, acute coronary syndrome, everybody can pick it up. And then for the chronic coronary diseases, that's where the problem is. But when a patient comes to you with hypertension, telling you that I have exertional chest pain, this pain is tight, it radiates, it's central, tightening, sometimes feels like heaviness on the chest, radiates to the jaw, tells you that it's associated with diaphoresis and feeling of doom, and it happens on and off, then you may be dealing with atherosclerotic coronary problems, and you need to investigate accordingly. Heart failure, dyspnea, orthopnea, PND, easy fatigability, bendopia, and then when you examine this patient, displays apex S3 telling you that there's volume overload, fine crepitations at the bases, swollen legs, and this symptoms, the left ventricular symptoms, failure symptoms can be seen in acute left ventricular hypertrophy. How do you evaluate this patient? Baseline ECG, you are looking at the rhythm, atrial abnormalities, whether they're enlarged or not, axis deviation telling you that perhaps the muscle is bulky on the left side and the resultant vector is looking at the left. So you can get left axis deviation. Then the criteria for left ventricular hypertrophy may be there, and then ischemic changes as well and bundle branch blocks. Advanced investigation. It's not everybody with hypertension who warrants echocardiogram. We need to know how to screen these patients and preserve their money and also practice well. So any abnormality from the ECG is baseline, as we've learned. So if you pick up the abnormality, or if clinically you think this patient actually needs more evaluation, the echo can be done. And it's looking at the structure, whether you can pick up atrial dilatation, hypertrophy, proximal dilatation of the aorta or aortic dissection. Function is very key in patients with hypertension, and they have ECG findings. Whether we have LV systolic dysfunction or diastolic dysfunction. This is where if the patient has heart failure, you can classify them as heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. And we all know that they are therapeutic implication of this nomenclature if you're able to pick it up. Sometimes you may have to do CT scan to evaluate the dilatation and also rule out aneurysm as well. Management, lifestyle, blood pressure control. If you have patients with LVH, remember that there are drugs that actually can help with regression. ACE inhibitors, ARBs, calcium channel blockers, they actually have favorable outcomes in helping to regress the LVH, especially when the degree of fibrosis is not much. And ARBs have been found to be most effective. How about heart failure? Management depends on the phenotype. If it's heart failure with reduced ejection fraction, for foundational drugs. But please, we should not box patients if they cannot afford the new drugs. They were old drugs before the new ones. If a patient cannot afford ANIs, it's not by force. If you don't take it, I'm not going to give you the older ones. Because ANIs are, I mean, healthcare is not just come, right drugs, let's go. It's economics as well. And the economics is not from your point of view as a medical doctor or a practitioner. It's from the point of the patient. So a patient says that I can buy ACE inhibitors. Yes, they can be on it rather than the ANIs. ANIs are sacubitril valsartan, that's superior in Ghana. If they cannot afford the SGLT2 inhibitors, EMPA and DAPA, amidst all the data we have, yes, the success stories, you cannot force the money is not there to buy. It's just no data cannot bring it. So you must practice within the confines of what you have and maximize the drugs we have. If they can be on their ACE inhibitors, MRAs, that's spironolactone, eplerenone, or they can be on their beta blockers as well, you give it to them. And when sometimes you can write a prescription for them, they go around and then they go and look for money. But you tell them that it's for a long term. It's not going to get 1 month money and come and say, so all these things must come to play. HFpEF and then mildly reduced EF, SGLT2 inhibitors have been found to actually decrease heart failure, hospitalization from heart failure and CV events. So they are good. For coronary artery diseases, acutely, you have to decide. Again, there are cath labs in Ghana. There are reperfusion strategies. You don't need a cath lab to do thrombolysis. If you can do it in your facility and the patient meets the criteria, please do it for ST elevation MI. If the person cannot afford, if the person can afford PCI, send the patient within the time that that is required for the patient to have an angiogram and PCI. In as much as we say that some people cannot do it, you'll be amazed. There are people who come into the consulting room unassuming, and we've met so many of them. You want to write them off. You tell them that, oh, you have this and this, just to look at the arteries is like $1,500, $1,750. They say, oh, that's not a problem. So you look at the person well. So please offer the best services to everyone. If they cannot afford, they will tell you. And then we should also know that coronary artery disease, there are drugs that impact on mortality. RAS blockers, antiplatelet, high-dose statins. In primary care, if we see patients with this history and they are not on the guideline directed drugs, let's do well to put them on it, because some patients may have been seen at the heart centers. They go back home, drugs run out, and somehow, some way, they'll tell you that I thought I was supposed to stop. And they come back and run to the primary care because they know that place they can dribble us. But so far as we are there and we look at their history, we can also help and give them the necessary drug. Arrhythmias, atrial fibrillation, atrial flutter, CHA2DS2-VASc score, has bled or hemorrhages score, and then you decide anticoagulation or not. And then you decide whether you do rate and rhythm control with the antiarrhythmics drugs. Aortic dissection, when you see this, keep the blood pressure 120 or less, heart rate 60 beats per minute or less, and refer urgently to the cardiothoracic surgeon. How about hypertension and kidney? CKD can happen because of structure function lasting for about 3 months. And the indicators or markers of damage really, you can albuminuria, you can have certain urine sediments to tell you. And more importantly, what we do for patients, and it's basic labs we do for hypertensives, the EGFR, and looking at the creatinine level. And we should be careful because sometimes, take the history, sometimes you have advanced damage before the creatinine comes up. And so the early markers like albuminuria is key. So labs like the urine ACR, albumin creatinine ratio, right as part of your hypertensive screen should be done because you pick up the early markers of damage right before you see the creatinine going down. Blood pressure is independent risk factor for kidney outcomes. And Dr. Stildazi spoke about the phenotypes, whether you have max hypertension, you come to hospital, and because of our faces, you are afraid, and the dresses we wear, and which are real, which is real. Some also can come to hospital, and strangely, BPs are high normal. 138, one. You do an echo. Recently, there was a young guy who came. The doctor did excellently. BP was borderline. So strangely, the echo showed mild left ventricular concentric hypertrophy. And they gave him a paper to go and check his BPs. You know, sometimes people don't want to take, I'm not saying that's what the guy did. If people don't want to take drugs, they can write good values for you. But this guy did it well, and everything was fine. So that the doctor actually asked for ambulatory BP. And this is what we should be doing. If we are attending to patients, it's not only the office, no, Dr. Sodazi said no office, hospital, because so it's not only the hospital-based numbers. Sometimes they look normal. The problems will be going on. So this guy had ambulatory BP done, and he had nocturnal hypertension. And so that was the driver actually. And nocturnal hypertension correlates well with cardiovascular event. So sometimes if we are not sure, 138, 139, don't say it's less than 140. Your BP is excellent. You can know. Please, when you see that, please, and you suspect that this patient might be having, especially with a strong familial history, especially with the fact that the person had other cardiovascular risk factors, you need to do out of office BP measurement. How do they present kidney problems? We all know it. They can be asymptomatic. There was this the student were teaching on the ward, and then this patient had creatinines were in the thousands. So we said, oh, it's CKD, my hospital. The guy said, it can never be because the legs are not swollen. I said, okay. It can never be. It can be. They are asymptomatic, but sometimes it's just through the labs. We pick them up. Legs are not swollen. Because those are the initial stages, and there's no decompensation yet in whatever target organ. So basically, they can come with nausea, vomiting, muscle cramps, loss of appetite, swelling of the feet, itchy skin, abnormal sleeping pattern. I'm not saying when you are sleeping whilst they are teaching the CKD, but sometimes we all do. That's not abnormal sleep, but some have reversal of their sleeping pattern. And if you've seen CKD patients, sometimes they are waiting to see, they are sleeping because sometimes in the night they are not able to sleep well. Apathy, loss of mental concentration, chest pain may come from acute coronary problems or uremic pericarditis. We should think examination. There may not be anything to suggest that the person has a kidney problem. Sometimes facial body swelling, skin pigmentation, scratch marks, uremic frost, fine crepitation for pulmonary edema, pericardial friction rub for pericarditis, uremic, distant heart sounds, then you suspect pericardial effusion. And when the patient is having flap, then you know the person is having encephalopathy. How do you evaluate? Blood urea electrolyte is part of our hypertensive screening. And if the eGFR is less than 90, then there's a problem. And also, as I said, urine ACR should be incorporated to our normal labs for hypertension because it detects the early markers of kidney damage. And then there's what we call renal resistive index, telling us that there is increased impedance to flow of blood in the kidneys. And that's telling us that there's renal dysfunction, and it also predicts cardiovascular events. Ultrasound should be done, and that will tell you abnormalities. For patients, and especially secondary hypertension, and you listen, examination, you hear a brew, and you are suspecting renal artery stenosis, it can also, if you do an ultrasound with Doppler studies, you can pick that up, especially in young people, fibromuscular dysplasia, which narrows the renal arteries. And for elderly people, really stenosis is due to atherosclerosis. So I took this from one of the nephrologists, and it's very good for us as primary care. And when it comes to nephrology, we are all primary care, because if you are not sure what you are doing, you refer to those who can deal. But this slide, I don't know if you can see, we share the slides. It actually tells us, no, now in classification of CKD, it's not just the EGFR. You need a EGFR and you need a protein loss albuminuria as well. So now you can say G3, that is a glomerular filtration rate, stage 3, and then A2, albuminuria is within 30 to 300 mg grams or 30 to 30. And that is telling us that there's microalbuminuria. So then it's not just the EGFR. So when you see this from stage, we can say stage G1 to G3 with mild albuminuria, you can keep the patient and monitor. But if you see significant albuminuria and you're having a patient with stage 3B, 4, 5, I don't think you have a business keeping that patient. And if you are going to monitor that patient, even for the early stages, you should know what you are about before you keep those patients. But if you don't know much about handling them, it's best we refer them so that these patients will get the best of care. If you want to monitor them, remember that you need to check their calcium, phosphate, parathyroid hormones, iron studies, the blood-borne viruses, and as well urine ACR to help you. And you must consider, sometimes we also do not have to flood the nephrologist with everything. If you see a patient with mildly reduced EGFR, albuminuria, just microalbuminuria, and there are no other pressing issue for referral, you can stop it by giving RAS blockade, and then over time, the patient can see the nephrologist, or else we will send everybody to them, and that also increases the burden of their care. Hypertension and the arteries, I think we can talk about ankle brachial index, which we all know for peripheral arterial disease. A low ABPI of less than 0.9 indicates lower extremity arterial problems. A high one greater than 1.4 is telling you that there's calcification. And for that matter, the vessels are not compressible. And this actually, patients can present with the symptoms we know about. I just put this in for the one I didn't talk about, the carotid intima media thickness. Really, in primary care, we may not be dealing with this, but all that is telling us that there is thickness or atherosclerotic processes going on in the carotid. If you're able to pick up this, you know that patient is at risk of atherosclerotic cardiovascular disease. And for peripheral arterial disease, please, we have to find out. It's always difficult. Patient comes in with, when I walk, I feel pain. As to whether it is neurological or is vascular, you need to find out. But again, we have to investigate. I mean, especially for the older people, when they come and they say, oh, it's just your age. Sometimes it's not just age. Real things are going on for people with hypertension and the elderly. And we can examine them as well. And if we make that diagnosis, we can actually manage them with controlling the BP, telling them to stop smoking, managing lipids, glycemic control if it's there, weight control, and then there are some other drugs that we can use, sometimes aspirin or low dose combination of aspirin and then anticoagulation. One thing I also want you to note here is that endovascular and surgical revascularization of severe peripheral arterial disease is available in Ghana. So you can refer to surgical block. Dr. Wu is there and she does procedures. Sorry. And Dr. Mark, yes, they do the procedures and help out. The last but not the least, we've been listening to quite a lot of things, but this part excites everybody. I'm even excited myself. So let me sit well. Let me sit well. But unfortunately, it's just 2 slides. So the excitement will be cut short. So for this is real. Erectile dysfunction. So diagnosis of hypertension increases the risk for erectile dysfunction. Somehow, it's so big for the men. I don't know whether the women are able to control their own because drugs can affect sexual drive of women as well. But as for men, it's just a different ball game altogether. We will get opinions after after. So ED can be an early sign of systemic vascular disease, including hypertension. And it has a negative impact, not just for the men alone. The partner also will complain by all means. Or yes, at some point in time. And for healthcare professionals, when I had a patient, 90-year-old, no, 95. He's blind, hypertensive. He can't see. He's held into the consulting room. Now, after every consultation, after consultation, they say, Dr. Kachompeso, I want them to go out and I'll tell you something. So I said, okay, what's that something? He said, oh, my thing is not working well. 95 years. But you see, it's not just 95 years. This is a real issue for the patient. And if they suspect that your drug is even adding to it, that's it. They are not going to take it. So you need to sit down and go through with them. So it's Robert Kloner said that healthcare professionals need to view ED as a potential cardiovascular factor and not just a urologic or psychogenic disorder. Sometimes we are quick to dispatch this patient. And there's an interplay. And in hypertension, you have the increase of angiotensin 2, endothelin 1, aldosterone, and all those, these are potent vasopressors. And for erection, you need dilatation in the cavernosum. And so the ones that are really good, nitric oxide, hydrogen sulfide, angiotensin 1 to 7, they are vasodilatory, but somehow the levels go down. And then they have the erectile dysfunction, coupled with the fact that there's oxidative stress. And if he's not able to perform once, then the psychogenic issues will add to it, and the anxiety performance will all come in. We need to investigate also. And in this patient, what do you do? Sometimes you need to do the hormonal profile of the patient, and then we need to look at the drug. So for antihypertensive drugs in this regard, it's a double-edged sword challenge. Some antihypertensives, which really decrease cardiovascular events, can negatively impact on sexual function. And so top among these, the diuretics, the beta blockers, and the centrally acting ones. And it's good. The centrally acting ones, we don't use them much. And so now it's the diuretics and the beta blockers. The patient has MI. He has to be on beta blocker. He's telling you that he cannot perform. What do you do? But there are beta blockers that are coming up now. Nebivolol is an example, the 3rd generation. It has very excellent response. And their patients have just swapped from other beta blockers to nebivolol. It's like magic. Because they also, apart from the beta blocker activity, they also release nitric oxide as well, and they help with the dilatation. So in seeing this patient, it's a balance between optimal blood pressure control and patient compliance whilst preserving the quality of life of sexually active patients. And so the clinician must be sensitive to what is important to the patient and not what is important to us, so that we can help out. So the take-home points are hypertension is not just increase in pressure propagated through vessels. Hypertension, when not controlled, affects vital organs supplied by vessels in the body. Hypertension-mediated organ damage, which are complications, increases cardiovascular events like heart failure, coronary artery disease, kidney problems, and peripheral arterial disease. Complications of the hypertension must be sought at every encounter with our patients with hypertension. Early recognition and treatment of hypertension prevents the complication, and we can make the difference as key stakeholders in this arena. I also want to remind you that Dr. Stoldazi made reference of the national guidelines for management of cardiovascular diseases. There is a national guidelines. It's not that we have a standard treatment guideline, but the Ghana Heart Initiative with the Ministry of Health and Ghana Health Service and Bayer and some partners came out in 2019 with the national guidelines for management of cardiovascular diseases. It's actually in an app form, so you can download it. It's called the Akuma app for the CVD guidelines in Ghana. Very good. All the cardiovascular conditions are in there. It can actually help you to take care of your patients well. Thank you very, very much for your attention.
Thank you very much, Dr. Nani, for such a comprehensive presentation. I mean, I think there's one thing that we should take note of and go home with it. It says that primary care physicians, we are supposed to change the course of the disease. We are the first point of call. And if we don't help, most of these people are going to have complications. We need to change the course. And remember that most of these complications, it says that are asymptomatic. The fact that the person is in front of you jumping and rolling around doesn't mean that there's nothing going on. We need to investigate, pick them at the early stages so that we can manage them and prevent the late complications where much cannot be done to help these clients. I'm sure people are putting their questions together. I have some interesting ones here. Please, Dr. Stoldazi and Dr. Setnani, get ready because there are massive questions that are coming over. But before we go to the questions, and as we put the questions together, our sponsors will be, giving us a presentation. Of course, after the lifestyle, there's pharmacotherapy, where we need to use some medications to support these clients and control their blood pressures. And Symbiotica with Sanofi are going to tell us that they have some great medicines that will do the job for you. To do the presentation for us, for Sanofi is Nellen Ofori from Sanofi. Remember that Symbiotica is a group of has a lot of subsidiaries. Sanofi is part of them. So Nellen is with Sanofi and will be giving us the presentation. Nellen, please, your audience. Kindly go to the questions section, and please, everything that is bothering you, don't wait till they leave here and be sending me messages. They are here to answer all the questions for you. So please, kindly put all the difficult ones. Some of them, they are so difficult, I can't answer you. Please, they are here. Send them on. They would answer all your questions for you. Thank you.
Okay, good afternoon, ladies and gentlemen. My name is Nellen Ofori. I'm a medical sales rep with Sanofi. Today, we've heard so much from Dr. Stoldazi and Dr. Nani, and Sanofi has some solutions to some of the problems that we have spoken about today. Sanofi has been a partner in anti-diabetics and anti-hypertensives for quite a while. And today we are partnering this program to bring you management to hypertension and how best we can give the best treatment to our patients. Okay, so the objective for today's presentation is to demonstrate the benefits of powerful BP reduction and then how to risk stratify patients and bring them the best of treatment, because it's very important that we risk stratify patients and then give them individualized therapy. So just a little bit of statistic. About 3 in 10 adults currently have hypertension. And out of those who have hypertension, only 1 of them are aware of their hypertension. However, of those who are aware of hypertension, only 8 of them out of 10 are being treated. But sadly, averagely, only 5 out of 100 people with hypertension achieve blood pressure targets. So many things could attribute to this number being so low. One could be patients being non-compliant, because as we know, when patients come into clinic and they write some drugs for them, when they go home, they do whatever they like with their drugs. Most of them are non-compliant and they will come back with complications. Others can't afford some of the drugs that they are being written. And then sometimes in clinic, as the doctors mentioned earlier, a lot of clinicians are into clear patients faster so they can leave clinic faster. So there is a bit of inertia when it comes to their treatment. We don't assess patients and then give them the right treatment as we should. So the ESH guideline says that if you reduce blood pressure, that's the systolic blood pressure, by 2 millimeters of mercury, you can reduce the risk in ischemic heart disease and other vascular disease mortalities by 7%, and then 10% reduction in the stroke mortality. And that is just 2 millimeters of mercury decrease in systolic blood pressure. So imagine if you're giving your patient a treatment that is going to reduce their systolic blood pressure by 10 or 20 over time. Also, the positioning statement, as we should note from the ESH guidelines, says that BP lowering treatment should be based on cardiovascular risk and target those at greatest cardiovascular risk, irrespective of their BP. From what we've heard today, there are patients who could have a grade 1 hypertension, but because of their other risks that they would come with, being obesity, diabetes, and then dyslipidemia and other risk factors that they would have, they are more prone to other complications that we should look out for and then treat these patients accordingly. Now, if these patients come to clinic and then we are informing their pharmacotherapy, there are things that we should look out for when it comes to the drug. The power of the drug, the protection that the drug offers, besides it's lowering their BPs, the other indications and then protection that these drugs offer. And then over time, since their management is going to be for a lifetime, the persistence of the drug to sustain them for the rest of their life. For the sake of today's presentation, we will be focusing on protection. So this is the hypertension and renal continuum. As we've heard from Dr. Nani today, hypertension can affect the kidneys. And then there are so many things that we should look at. In patients who are hypertensive, worst case scenario, have diabetes as well. One of the earliest indications of renal disease is microalbuminuria. It is the earliest indication of renal disease. And then it's a continuum. So it keeps there are a cascade of events that happen when they are not being treated appropriately. The microalbuminuria could turn into macroproteinuria, nephrotic proteinuria, and CKD, and then if not intervened, death. And I know we have been practicing for a while, we have success stories, and then we know there's so much more we can do for patients who even present with microalbuminuria. And then we can reverse them and then give them good quality of life. So the drug we are looking at today is an ARB called irbesartan. It's one of the relatively newer ARBs on the market. Sanofi's brand of irbesartan is Aprovil. We have other combinations that come with amlodipine that is called Aprovasc. And then we have a combination with hydrochlorothiazide that is called Aprovil. It is a well-tolerated ARB and very potent in reducing blood pressure. And then it also has other indications in diabetic nephropathies and then erectile dysfunction, which we have all agreed to that are very important to our patients. So today to talk about irbesartan and then its benefits in kidney disease, we'll be looking at the IMA2 study. The IMA2 study stands for irbesartan in patients with microalbuminuria, which we've established that is the earliest sign of kidney disease and type 2 diabetes. In the IMA2 studies, 590 patients were sampled. 201 of them were given a placebo. 195 were given irbesartan 150 milligrams, and then 194 of them were given irbesartan 300 milligrams. The study was a multi-center double-blind study that went on for 24 months, that's 2 years. At the end of the 2 years, it was seen that those on the irbesartan 150 milligrams had a relative risk reduction to about 39% from the mean microalbuminuria that they started with. And then those on the irbesartan 300 milligram had the relative reduction of 70%. Now we've noticed that in the 150 milligram irbesartan, that was 39%, and then that of the 300 milligram, that's 70%. It's quite, there is some significant difference. That because the irbesartan's effect on microalbuminuria is strength dependent, meaning a patient will benefit more from the 300 milligrams, that is if they have a grave microalbuminuria as compared to patients with lower risk of microalbuminuria who would benefit from the 150 milligram, besides bringing their blood pressure down. So now that we have established that irbesartan is good for reducing blood pressure and then also giving nephroprotection, we are going to relate it to the guidelines that we use that we've already looked at through the presentations that we've had today. So the Ghana Cardiology Society has an algorithm that we follow, where we have the grades of hypertension and then some modifiable cardiovascular risks such as hypertension, diabetes, dyslipidemia, excessive alcohol consumption, tobacco smoking, obesity, that is a BMI greater than 30, physical inactivity, obstructive sleep apnea, and then some non-modifiable cardiovascular risks such as age, that is in men greater than 45 years, and then in women greater than 55 years. And then people with family history of premature coronary artery disease in males even less than 55 years, and in females less than 65 years. And then males are also more susceptible to cardiovascular disease risks than in females. So we'll be taking hypothetical patients. These are also, actually, let me correct myself by saying these are not hypothetical patients, because I know in clinic, we see patients like these with certain grades of hypertension and then these cardiovascular risks. So let's take a very, a case that would usually see in clinic. So we have Moses, he's a businessman, he is 56 years, and then his BP is 162/93. He's been living with hypertension for 3 years, and then he's been a diabetic for 2 years. His BMI is 31.2. He has an LDL of 5.5, and he's on modiretic 5 milligrams, and then amlodipine 10 milligrams. Now, from the parameters that we have from the Ghana Society of Cardiology, Moses has a grade 2 hypertension and then has more than 3 risk factors. So we will now identify Moses' stage of hypertension and then his cardiovascular risk, if he is at low, medium, or high risk of cardiovascular disease, and then what would be his choice of therapy. What is the solution Sanofi is offering for Moses? So we'll refer to this table. We've established that Moses has a grade 2 hypertension, and then he has more than 3 risk factors that predispose him to cardiovascular disease, meaning Moses is at high risk of cardiovascular disease. Now, Sanofi is saying that we'd consider single pill dual therapy at initiation. So Moses is going to be taking Aprovask 310 milligrams. As I've mentioned, Aprovask is our brand of irbesartan that contains irbesartan and then amlodipine. There is a wide range of Aprovask. We have 155, 150/10, 305, 310. Moses will be taking 310, and then it's expected that he's going to have an up to 18.4 millimeters of mercury systolic blood pressure drop and 8.7 millimeters of mercury diastolic blood pressure drop. And then in a study called the IR study, 61.7 of patients achieve control on being on Aprovask. Now we'll take another patient. Her name is Vera. She's 60, and then she has a BP of 182, 114, which is a grade 3 hypertension. Her LDL is 7.5, her BMI is 31.7. She's been diagnosed with hypertension for a year, and she's currently on amlodipine 10 milligrams, lisinopril 10, and atorvastatin 20 milligrams. So we are going to identify Vera's stage of hypertension and then inform her choice of therapy as Sanofi is suggesting. So going back to the board, we've established that Vera has a grade 3 hypertension, and then she has more than 3 risk factors that is putting Vera at a high risk of cardiovascular disease. So we are also going to consider a single pill dual therapy at initiation for Vera. So Sanofi is saying that we're going to give Vera co-Aprovel 312.5. Co-Aprovel contains erbisatan 300 milligrams and then hydrochlorothiazide 12.5. All the strengths of co-Aprovel contain only 12.5 milligrams of hydrochlorothiazide. However, there is a combination that is 150 and then 12.5 milligrams. It's expected that in 7 weeks, Vera is going to have an up to 31.7 millimeters of mercury drop in systolic blood pressure and up to 24.5 millimeter drop in her diastolic blood pressure. Remember when I showed you the positioning statement of the ESH guideline, where I showed you that 2 millimeters of mercury systolic blood pressure drop is going to cause about 7% drop in stroke mortalities and then 10% in other areas. So if she's going to have up to 31.7 millimeters of mercury drop, that means you're going to save Vera by a mile. We're taking our last patient, Halima, who is 45. Her BP is 145/92. Her LDL is 5.5. She has a BMI of 22.4. Her fasting is 1 to 1 milligrams per deciliter, and she's a newly diagnosed hypertension. Just like we did the others, we are going to stratify Halima's risk for cardiovascular disease and then inform her choice of therapy. So Halima has a grade 1 hypertension, and then she has 2 risk factors that put her at risk of cardiovascular disease, meaning she is at medium risk of cardiovascular disease. Now we are going to give Vera also a single pill dual therapy at initiation. So Sanofi is saying we are going to give Vera Aprovax 150 10 milligrams. That is erbisatan 150 milligram and then amlodipine 10 milligrams. And then we are expected to have an up to 17.9 millimeters of mercury systolic blood pressure drop and 7.7 millimeters of mercury diastolic blood pressure drop. Up to 72.6 patients on Aprovax 150/10 achieve control within just 10 weeks of being on Aprovax. So just a summary of the patients we've seen and then the initiation. So for newly diagnosed moderate risk grade 1 hypertension, we are initiating with 155 milligrams or 150/10 milligrams of Aprovax. For uncontrolled high risk grade 2 hypertension, we can always add on or switch to 305 milligrams of Aprovax or 310 milligrams of Aprovax. For uncontrolled high risk grade 3 hypertension, we are looking at 312.5 milligrams of co-Aprovel. So these are what the products look like. It's a once-a-day pill. It can be taken with or without food. And then the maximum recommended doses are 310 milligrams, that is for the Aprovax, and then the 312.5 milligrams per day for the co-Aprovel. But we don't have the 325 milligrams of the co-Aprovel on the Ghanaian market. The good news also is that for an innovator brand, we have the cheapest, or let me say relatively cheaper brand of combination therapy for hypertension on the market. So we are bringing you the patients the best care whilst being economically sound to these patients. There is no dose adjustment needed in patients who are old or patients who are renally impaired and then have impaired hepatic function. So the available multiple doses we have Aprovel as well. That is the plain irbesartan for monotherapy, 150 milligrams and then 300 milligrams. And then co-Aprovel, I'm reiterating, we have 150 milligrams, 12.5, and then 300, 12.5 milligrams. For the Aprovesk, which is our widest range, because of the amlodipine, we have amlodipine in the 5 and 10 in combination with the 153.5. So that is 155, 150, 10, 305, 310. So the classical side effects are the postural hypotension, fatigue, muscle or joint pain, headaches. They are contraindicated in children under the age of 18, pregnancy, and they are also contraindicated in pregnancy and then lactating mothers and then individuals who are lactose intolerant. However, in very severe cases of renal and hepatic impairment or concomitant use with a lescarin-containing product, it should be clinicians should be very cautious in giving these to their patients. So this is what the packs look like. I will mention again, Aprovel contains irbesartan. Irbesartan is the ARB that we are introducing to you today. And then that is for the people who've not heard of irbesartan before. And then for those who already know, it's a reintroduction. Irbesartan is a well-tolerated ARB that is indicated for high blood pressure and also an additional benefit of diabetic nephropathy, and then also benefits in erectile dysfunction. So then we also have it in a wide range where we have combinations with hydrochlorothiazide and then amlodipine, and then in very few cases where a patient would warrant monotherapy, we have plain irbesartan in Aprovel. Thank you so much for listening. If you have any questions, I'll gladly take them.
Thank you very much, Ofori. I'm sure the questions will come. People will be asking about cost. But now let's take the questions. Very interesting questions that are coming through. Probably I would start with Dr. Stildadzi. So someone is asking, you talked about white coat hypertension. It's really struggling with it. How do you deal with it? And I want to give some other questions that are related to it so that you can answer them all. See that he's really struggling with it. How do you deal with such? Because he has a lot of clients coming through, and the BP sometimes is in the roof, sometimes it's normal. How does he deal with it? So in that steps, I mean, what will be the steps that he has to take in correctly diagnosing hypertension? What are the ranges that you consider in diagnosis? Because somebody is saying that he likes reading and he saw some JNC8 and the values are different from what you are talking about. So which one is he taking? Is he taking Stildadzi's own or is he taking JNC8? Probably you can take it for us.
Right, thank you very much. So white coat hypertension, technically, it's a situation where an individual records high blood pressure in the hospital setting, but has a confirmed normal blood pressure in the home setting. So what it means is that, first of all, the blood pressure which is checked in the hospital should be based on the recommended protocol. And I think we've gone through it, but I'll go over it again. And then the person should have a normal BP recordings at home. But white coat hypertension has to be confirmed, ideally, with an ambulatory BP measurement. Home BP measurement is good enough, but we have to be mindful of the fact that in the home setting, BP is high blood pressure is 135
over 85 and above. So the patient comes with home blood pressure of 138 over 86. You don't say that because it is less than 140 over 90, that person has white coat hypertension. So the confirmation is very important. Be mindful of the figures. Go through standardized protocols to measure the BP at home. And one of the practical things I do is that I ask my patients to come to the hospital with their own BP machines. In these cases, so when they arrive at the hospital, we check with the hospital's blood pressure machine, and then we check with the patient's own blood pressure machine. So not before the patient checks at home just before setting off for the hospital. And when he gets to the hospital, we check. So clearly, if the patient recorded a normal blood pressure at home, and then he comes to the hospital and with his own device, as well as the hospital's device, the patient has high blood pressure, that is likely to be white coat hypertension. And we can, if available, ask for ambulatory blood pressure to confirm the normotensive situation at home. Another thing we can also do is to assess the patient for target organ damage. If you assess the patient for target organ damage, and indeed you see clear evidence of target organ damage, the patient has left ventricular hypertrophy, albumin creatinine ratio is high, EGFR is less than 60. That confirms that the patient indeed has hypertension. So in that case, that patient has to be treated with lifestyle and pharmacotherapy, especially if target organ damage is present. But the key is that we should make sure that the confirmation or the measurement of BP in the hospital setting should follow the standardized protocol.
The difference, I mean, talking about GNC.
Yeah, GNC 8.
Before you go there, I mean, this person you're talking about is in a control where they won't get ambulatory BPs. So how checks? So
yes, so it applies. If the patient has a device at home,
so home BP
yes, home BP management is good enough to confirm BP in such settings. So the GNC 8 guidelines is actually American guidelines. And what I presented was a combination between the Ghana guidelines and the European guidelines. I have to say that the Ghana guidelines takes a lot from the 2018 European guidelines. So there's a lot of similarities between the Ghana guidelines and 2018 guidelines. But the European version I presented is the 2023 guidelines. And that has a bit of difference, especially with regards to the recommended BP targets. So you'll definitely find differences between that and the GNC 8. GNC 8 is pretty much an old document. It was published in December 2013, even though the Americans have also had updates, but there are differences between the American guidelines and the European guidelines, as well as the Ghana guidelines. So we need to be careful relying on the GNC guidelines. I would recommend that we rather rely on our guidelines, which is very comprehensive.
So that's the problem. Let me add to this person's questions. You are saying that our guidelines was taken from the European guidelines, and there's an American guidelines. So why should we take the European guidelines and not the American guidelines? Do we have our own data to guide? What our guidelines should be in terms of targets. I don't know why we decided. Is it that they have more of data that applies to us, or it was just because of other things?
Yeah. So when you go through the guidelines on our recommendations, one of the key things we need to pay attention to is what we call the evidence rating. So in our guidelines, you realize that every recommendation has a cited or a level, an evidence rating. So you know, it's graded as A, B, C. So the higher the level of A is higher than B and C and so forth. It's the same with the European guidelines and the American guidelines. So what is really, really important is the evidence rating. And if you look at our guidelines, most of the recommendations are based on level evidence rating A. So even though we may say we lean towards the European in some aspects, the guideline was actually based on evidence review by the committee that did it, rather than take the European guidelines hook, line, and sinker. It was not actually an adoption of the European guidelines. The committee did a very thorough job reviewing evidence. So it is not a clone of the European guidelines, but what they saw fit. I'm sure they also regarded the American guidelines and all that. And actually, when you go through the European guidelines and the American guidelines, they give a basis for their recommendations. And if you look at the recommendations, they are quite sound either way. So it's a matter of preference of some of them. If you look at some of the cutoffs for diagnosis of hypertension, some of them, the considerations may be clinical, some may be epidemiological. If you decide to go for a lower cutoff, you know the implications. Your healthcare bill will shoot up because so many people have to be treated with hypertension. And the question is, what are the benefits? So even though somebody can say that, oh, for me, I'm deciding that hypertension is 130, 80 and above. The question is, what are you relying on? Are you relying on the benefits or, I mean, what is it? Are you also looking at economics? So they took all these factors into consideration and then they decided on the evidence.
Thank you very much, Doctor. I think I'll ask you a question that you can add it to it, okay? Because your rectal dysfunction is featuring prominently here. So somebody's also worried about it because I'm sure a lot of primary care physicians are facing this. I mean, 80-year-olds, 90-year-old, I mean, telling you that, I mean, that thing is not working well. What should I do? Somebody is saying that, yeah, though the hypertension itself is a cause. And I must say that a lot of times when you are dealing with a client, we need to let them know that the hypertension itself causes it. A lot of them think that is the medication. They don't take the medication and they come later with erectile dysfunction. And I mean, by that time, probably, got into a stage that is difficult. But he's saying that he's giving the medication and the client is saying that to take the medication for that thing to go down, he would rather die. So what are the best options with medications in terms of antihypertensives that he thinks that he can choose from that has the best in terms of that? And those that are having issues, what should they do in terms of how do they go about the management and dealing with it and in talking to the client?
So, thank you very much. ED really is a big issue. So for these patients, as you rightly said, education is key in helping the patient to understand what is happening. So if the individual can understand that the underlying disease condition can actually cause what I'm having, and also the drug cannot, some drugs, not all the drugs, and it's not all the time, can also cause it. And then you tell the patient the effect of not taking the drugs, then they are ready to dialogue with you, not just to accept, but to dialogue with you. And now when you start the dialogue, as I presented, there are drugs that are found to be, they are found to have more effect causing the ED. So the thiazides are known for that. Beta blockers are known for that. And the centrally acting ones for men, methyl dopa, clonidine, reserpine sometimes. But again, studies have also shown that the newer beta blockers, especially nebivolol, has been found to even have a positive impact on the erectile dysfunction. So you tell the patient, ARBs
have also been shown that they don't really cause that. So you can choose between this. If the patient is on one drug and you change, or is on one drug, you can change to the other, and the patient must work with you. If it's still persisting, we have many other drugs that you can actually change. And whilst you are working with the patient and telling them, you are doing the change as well. But we shouldn't be quick to blame only the drugs. If it's going on like this, you need to do the hormone profile of this patient. You need to check the kidney function of this patient, liver function of this patient. Perhaps there's a problem with this. So if you're able to get the underlying diagnosis, but the first point of call, if the person was okay and you started the drug and the symptoms came about, yes, you start modifying your medication. But if you change and it's not helping, then you must go and then check all the other possible causes. You check, as I said, liver function can give males problems. Kidney problems can also result in that. And especially when you are going, some people's testosterone also comes down, estrogen is going up. And so if you find out, then you can actually refer them for them to be helped. Yes. Now, for others, you check and check. It's a pure atherosclerotic problem. That is why some interventionists have specialized in the pudendals. So in as much as we can open the coronary arteries, it's amazing. Catheters can be sent to open the pudendals as well. And that is the last end of it. I don't think, yes, we have a Ghanaian professor who does it, and he comes around Ghana and he goes, but he does it in UK. He's renowned for that. Yes, for whether to choose the new American 130/80 or 140/80, you must, one, be careful. You must know the jurisdiction in which you are working. And as Dr. Sildazi said, Ghana is using the 140/90 cutoff point. The whole of Europe is using it. The only people who have actually chosen 130/80 and the Americans, and they are basing it on a study they did. And they have a point, because as Dr. Dazi said, the problem with CV events starts from 115/75 of BP, and then it goes up. The 140/90 was chosen because it is at that point that benefit outweighs the effects that you have with the drugs. Now, the Americans did a study called the SPRINT trial, and they found out that the people who had BP more than 130/80 had increased cardiovascular event. So what did they do? Yes, they adopted it in their newer guideline before. The Europeans are still sticking to the 140. Why? Because the strategy they use in checking the BP is not what we do at the clinic. What they did was that it was unattended BP checking. So the patient comes in and they leave you in a room, nurse is not there, doctor is not there. So they take away the clinical setting. If that is what you are going to do at your clinic, then you can go along with the Americans. You have a room, you use how many hours to tell patients how to sit down well. And that was a steady setting. Now, when you flip it to clinic, so the Europeans are saying that if you just oppose it, unattended BPs like the one people carry home and all that, that is why it is low. That is why the cutoff for ambulatory BP, daytime is 135, night is 120/70, overall is 130/80, unattended to by health workers. But as soon as the office thing comes in and we are there, so they have a setting. So if you are going to go with the Americans whilst you are in Ghana, you must make sure that your setting mimics what they did in the SPRINT trial and got that. But by and large, I think the Europeans there are enough studies for the 140/90. And this one came in, and they also have their reason. You can't blame them. But you see, even in their treatment, they don't just give drugs at 130/90. As Dr. Stildazi said, they add risks to it. So the CV risks to it. So it's not like come 130/80 as soon as they measure. So when you look at the two sides, and when you come 140/90, it's not that we start. We also look at CV risk factors. And there's even high normal for the Europeans. And even if for those people, if you have CV risk factors, as Dr. Sodazi said, we also treat. So technically, when you look at the thing, really there's no big difference in it. So but let's go by 140/90. It's in our guidelines. It's in what most European, even the 2023, the recent one, European Society of Hypertension, they are abiding to it. UK abiding to it. Everywhere abiding to 140/90. So I think that should add to the list.
Thank you very much, Dr. Nani. I think that that explains it. Well, because I know even the physicians in the US actually decided that they were not going by that. Yes, exactly. So there was a lot of this thing with even the start of treatment. But Dr. Sudan, it comes again to you that BP measurements really a big problem, because there are times that people go to the pharmacy, you don't know how it's measured. They bring you certain figures. Even at home, I saw a client, how do you check it? And where the curve was already a big problem, but they'll bring you values and you're not sure. So somebody's asking, so with all this, how do you go around it? How many minutes apart? We tell them probably do 2-3 readings. Is it that you finish one, go and eat fufu and come back and do it, or just a minute apart? And he's saying that when you've done all this and you've hit your, at what point do you say that you are starting treatment? And people start treatment, BPs go to 120/70, 120/80. The patients are very happy. They come, doctor, stop my medication. When do you stop taking the medication? When do you stop the client from taking medication? So if you can deal with this one, then I think I'll be done with you.
Right. Thank you. So as I took us through, there are 3 things we need to check BP the standardized way. Checking BP in pharmacies, barbering shops are very much part of recommendations for checking in the diagnosis of BP. It's part of screening. And that is what is called opportunistic screening for hypertension. So it's very much encouraged. But currently, there are no standard values or thresholds for defining hypertension in those settings. I'm not sure whether we should regard them as office, that may be a proper office, and then, or home. So, but in any case, those ones should be confirmed with hospital checks. With regards to checking BP the standardized way, there are 3 things that are involved. 1, the device. 2, the protocol, that is the standardized protocol, and then the process. With regards to the device, we talked about recommended devices. Currently, we use is it the electronic one? Yes, which is very much recommended. But if you are using the non-mercury cuff ones, that is also recommended. So the other thing is that it should be calibrated. And the calibrations are normally specified in the device manual. So every device has its own guidelines on its standardization. So very important. And with regards to the device, again, we talked about cuff size. Cuff size should be appropriate. For the manual ones, it's easy because there are some indications on it. Sometimes you don't pay attention to it, but there's something at the underside of the cuff. It's called the range. You see an arrow pointing, 2 arrows pointing outwards. And if the cuff size is appropriate, the edge of the cuff should fall within that range. So even though we may talk about measurements, if you are using the manual cuff, that's a very good point to use. But the electronic ones don't have those marks on them. So you may have to look at the device recommendations on what is appropriate. So having talked about the cuff size, the next thing is the standard protocol. And I think we went through that. I'm not sure whether I can, let me see if I can project it again to make it easier. Okay, so basically, first of all, the patient should be seated in a very comfortable room, no noise, quiet. The back should be resting. The legs should not be crossed. That's the one I don't understand. Because me, I think my BP will be best when I cross my legs. Then the patient should be made to, in that position, the patient should be seated for 3 to 5 minutes. The 3 to 5 minutes is not at the OPD waiting area, but in the seat where the BP is checked. So that will help to relax the patient. And when the cuff is applied, it should be that the arm of the patient should be resting at quite close to the chest, and the arm should be at the level of the heart. So the cuff is applied, the BP is checked, and at any given time, the BP should be checked 3 times. That should be 1 to 2 minutes apart. And interestingly, is the latter 2 that we use. The first one is discarded. So the latter 2 are average. So you see how wrong we get it. Our patients can we check it only once. The one that is not recommended for us to use, that's the one we rather use. And that applies even for patients, not only for confirming diagnosis, but the patient who has come for review. So to confirm BP diagnosis, 1 is not enough. I'm talking about the visits, not the checking, the individual checking at a particular visit. So within a visit, you are doing 3 measurements and you are taking the average of the 2. Then after that, the patient comes at least another time within 1 to 4 weeks, depending on the person's risk. So if the patient has a very high risk, that one, we have to put a caveat on it. Patients who have very high risk, BP is very high, stage 3, do not need subsequent visits. Patients with stage 3 and evidence of significant target organ damage, right from the beginning, the BP is confirmed. You don't need to let them come another time. But those with less BP, depending on their risk, you schedule them within 1 to 4 weeks. They come at least 1 more time, but they can come 3 times. You check the same procedure on those occasions also, take an average of the latter 2. And then if based on that, the patient is within the hypertension rate, that is 140/90 or more, then you confirm hypertension. Right.
When do you stop the medication? Somebody's actually said that mercury fixed are not recommended. Somebody's asking why. And someone's
So
asking
I
why
think
do
that
we
is
get-
because of the potential toxicity of mercury as a substance.
Somebody's
Being a heavy
asking
metal.
why you're having differences in both arms if you are checking BPs.
Yes, so to start with, significant difference in 2 arms is when the variation is 10 millimeters of mercury or more. If it is just 2 or 3 or 5, it's not really a big deal. But it can happen, and those are usually caused by significant arterial disease like coarctation of the aorta or very significant atherosclerosis. So when you have a situation like that where BP in the 2 arms differ by 10 millimeters of mercury or more, what is recommended is that you should note the arm that has the higher BP, and that should be the one that is measured from clinic to clinic. So it does happen. And what's the next question?
When do you stop taking medication? Is it that when
But generally, antihypertensives should not be stopped. They should be continued. However, there are a few cases that they can be stopped. And those include secondary hypertension that the underlying cause has been cured. So I had a patient with pheochromocytoma who had excision of the tumor in the adrenal gland. After that, BP normalized. So there was no reason to continue the BP. Somebody has BP secondary to hyperthyroidism, thyroidectomy is done, BP goes down, you can consider stopping the antihypertensives. Or a pregnant woman has pregnancy-induced hypertension. After delivery, BP obviously goes down. You can stop the antihypertensives. And also, there is what is called de-intensification of antihypertensives, which can be done in elderly people whose BPs go down. So you have an 80-year-old already taking so many medications. As people grow old, there's a tendency for BPs to come down, especially the diastolic. So if the person comes, BP is less than 128, you can, and he was on 3 drugs, you can stop 2, keep on 1 and monitor. And it will be good to use home BP measurements to monitor in those circumstances. So, but apart from those, generally, BP medication should be continued.
Thank you very much, Dr. Stodaji. Dr. Setnani, this is coming to you. So some of the actions that we've talked about, how to prevent complications. You talked about the artery, talked about the carotid intima thickening, and checking for the peripheral artery disease, the brachial ankle brachial index. But people don't check those ones in our environment. How often should they check it, and how often should they do routine checks for these complications at their clinic?
So, thank you very much. What you screen for in terms of complication will be based on the history that the patient is coming with. Carotid intima, for example, when someone comes with symptoms like TIA, you would like to go and listen over the carotid. And if you hear a brew, that suggests that perhaps as part of your, not just take the stethoscope, go straight to, as part of your examination, you need to listen over the carotid. If you hear a brew, then there's actually significant intima narrowing or be a plaque. That's when you go on and then you actually investigate for that. So it's driven by your history and clinical findings. You are not going to screen every hypertensive for any and everything at any encounter, because then it doesn't make clinical, it's not right clinically, and then economically as well, you'll be wasting everybody's money. So it's the history. If the person comes and say, my vision is blurred, you know what to do. Fundoscopy is needed if you can do it. Someone comes, as we said, I can't breathe, I walk a little bit, I'm tired. You go for echo to investigate that. Someone gets symptoms, syncopal, TIA, you go and listen to the carotids, and then you as well do the scanning for the carotid intima. So it's basically driven by what you find out from the history. I also want to add that we should not, if in the peripheries, you see this a lot, someone is taking medication with the, when do we stop the drugs? BP comes to 130, 120. The next thing you hear is that they stopped me on that because I was normal. But the question is, you had your hand on a ball on water, and you're able to press it down under the water, and you are happy that I've pressed it, so I'm taking my hand off. It's going to bounce back with all these complications, unless, as Dr. Steele said, the conditions he gave, and when somebody clearly is having orthostatic hypotension, BPs are dropping 90, 60, even that you de-escalate a little bit, and best you use your ambulatory or home BP to monitor the patient very well. But I think the patients are able to push quite a number of doctors when the BP is normal, but we shouldn't do that at all.
Dr. Senan, before I release you, because in your statement, you said that most of these complications are asymptomatic. So which ones, are you recommending that at least yearly, these routine ones are done for hypertension so that you don't get into this? Because, the way you went about it, people may stop doing certain investigations. So if you could, clarify that a little bit.
Yes, so for baseline investigations, yes, yearly, you do your full blood count, and it will tell you if HB is going down with no significant cause. It tells you that go and look at your kidney. But even with those labs, you do the blood urea and electrolyte. You find the EGFR there, whether it's going down, creatinine is going up. You add your urine ACR, because those are the early markers, albuminuria, add it to your normal hypertensive screen. You do your lipid profile. If it's high, it's telling you that the risks of atherosclerotic events are high. You also want to do your urine RE to tell you about proteinuria. ECG is basic. That's where you pick most cardiovascular issues, arrhythmias, left ventricular hypertrophy. And so those things are basic. And then history and examination wise, you examine the patient, you listen to the patient's heart. If you're having a third heart sound, a fourth heart sound is telling you that go and look at the heart with an echo. Maybe fourth heart sound is telling you that hypertensive heart disease, LVH. Third heart sound means maybe fluid overload, and there's left diastolic dysfunction, and the heart is not working as it should be. So these are JVP rays will tell you that go look at the heart. Maybe the heart is failing. So as for the labs, the basics are those that we've mentioned. If there is a cause to go further, that's when you start picking up. If you find something wrong in BU creatinine, you go on to do your abdominal scan. You are looking at the kidney, the renal Doppler. And then if you have something wrong with ECG, you go for echocardiogram, you hear a brew, you do your scan for carotid intima. So one thing leads to the other, as they say. But your basic investigations are those that we've outlined. And I think Dr. Stodazi made mention, and they are in the slides.
Thank you very much, Dr. Seth Nani. Pharma Symbiotica and Sanofi. So somebody put in there that, wow, he's hearing about your Aprovel. What is the cost and where can they get it? I mean, remember that most of the people who are listening to us are from Cocotro and NG. So they're asking what's the cost and where can they get it? I mean, can they get it everywhere?
Okay, so during the presentation, I mentioned that the good news is relatively for an innovator brand, we are the cheapest combination therapy on the market. And the cost between the Aprovel, which is a monotherapy, and then the Aprovas, the highest, that's the 310, is between 180 to 320 on retail. Yes, on retail. 1 month. Yes, that's 28 days a pack. Yes. Retail, every retail pharmacy, yes. It's available in all retail pharmacies across Ghana. And I think a lot of institutions also have it in the pharmacy as well. So if you don't get it from the hospital, just across the street, any pharmacy you walk into, you'll find it there. Just 180 to 320 cedis. So it's a win-win situation, especially for an innovator brand.
Yes, hello. Thank you very much for the presentation. So I have two questions. My first one can go to both speakers. So the reality on the ground is that most of our patients, we don't have the right BP cuff size. What is the way forward? Because we are going to tell these patients to go home and check their blood pressures. At times, I can roam various pharmacies trying to get, but it's not there. The pharmacy is trying to get the right cuff size for my hospital, but it's not there. And I'm sure most doctors on this meeting are having the same issue. So what do we do? My second question is, Dr. Nani, you made mention of calling stroke units. Now, considering time to needle being 3 hours for some people and 4.5 hours. Now, if I'm from Kokrobo, where Dr. Kokotro, considering that time, we will make it. Is there a rule for these to be done at primary care? As a family physician, can I thrombolize? Thank you.
Wow, excellent. So let me start with the thrombolysis. It's not a preserve of only neurologists. Medical officer who can do it and be able to define the patients with the features, you must be able to look out for the contraindications, rule them out. It's just an IV medication you are given for. And after that, yes, ICU care is important after that. But people have thrombolized at places where they had a bed. So as soon as you are done, you put everything on the patient. There's a monitor, maybe a nurse to help monitor for the next 24. When they come on shift, eye is on the individual. And then you check your BP, sugar is being checked, temperature checked. You're also checking out for any bleeding tendencies. And that's it. Unless the person is really sick, that you need an ICU to do it. But wherever you are, a family physician is you are even well positioned to do it. Yes, and the good thing is that when you call the stroke center, they can help you stage by stage and you will do it. And people have done it with them, basically. And then we have a call center. I didn't mention that. There's a call center in Kolebu. It's the cardiovascular call center. There we have consultants on call. We have fellows in training on call for cardiology. So when you call, they can walk you through. They don't look for bed. That one, they don't do bed management. They will help you manage CV events. So please, the number, I don't think we have it here, but I think if you Google it, you can have it. As for the next question, I think the directors, yes.
Please let me add up to what he said. In fact, we are working with the Cardiovascular Initiative, the cardiovascular team, to actually help family physicians and primary care physicians with the guidelines to be able to start thrombolizing. The point is that in our setting, we need to. So there are discussions ongoing. I'm sure there'll be a CPD on it where we go through so that everybody will be at the same page, knowing the risk involved when you think that it's safe enough to start. Stadazi has done some at certain places and it was fantastic. People are doing it. But I think that we need to be trained to do it. The risk indeed is high if you don't do it well. So, just be looking forward to that. We'll do that CPD because it's a discussion that is going on to make sure that, because they will definitely start from the primary care. And of course, the traffic alone is 6 hours. And we will need to make sure that we can. The next question, I'm not answering that.
I think the directors and those who buy things and the logistics for their hospitals should help with that. Maybe you. But if you can't have it as well, now we have courier services right from everywhere into the country. And China is especially, you can have calves packaged and brought to you. It's not, so people are buying it there. So in your hospital, if someone can help and you are not getting it on the market, we can, because some of the ambulatory machines and all they are very good, coming from China, India, whether Europe and they are excellent. They have all the calf sizes as well. So you can actually, if you don't get it in Ghana, you can use the other services from outside and you will get it. Okay, thank you.
Thank you very much, Dr. Setnani and Dr. Stadazi, and our partners from Symbiotica. Wow. Okay, so because he's here, I will grant him the last question. So let's have from Sylvester.
Yeah, thank you. I think Dr. Stadazi answered partially. Some patients want to know directly, if I start taking drugs for hypertension, will I be on it for the rest of my life? And some of them, their BP is not too high for you to. So if that question is put to you directly, will I be on drugs for the rest of my life if I start? Is it yes or no? Not the secondary hypertension.
Yeah. So the answer is yes. The answer is yes, but whenever a patient asks you that question, you should know that that patient has concerns. And if you just answer yes, believe you me, they will not comply. You have to, that tells you that that's a patient who probably has not been adequately educated. So education is the key for such patients. Sit them down, let them know what hypertension means and what the treatment has to offer. So, there are notions out there which feed into the patient's minds. Some of them think that when they take the medication for a long time, it rather damages their kidney and other things. And that's a very common misperception. So we need to sit down and elicit what the details of the patient's concerns are and address them. I had a patient who came to me one time and said, "Doc, I'm tired of taking the medication. I want to stop." I mean, that's interesting because if you're a patient, you're on medication, you want to stop. Why don't you stop on your own? Why do you come to me? So I asked her a simple question that you say you are tired. Is your BP also tired? And she said no. So I sat her down and coached her on hypertension. And after, in fact, I pointed out her to a patient who had a stroke. And I said, oh, that patient who just left, sitting in the wheel, is a BP that did that to him. He left the consulting room swearing that she would never stop taking the antihypertensive. So it's about any time a patient asks that question, the answer should not just be thrown at him or her, but yes, they have definite concerns that you need to elicit and address appropriately.
I want to thank the presenters here. You know, I'm a little ancient among the group here, as you can see. I take care of a small clinic, you know, for the university, a private university. And I've made a small observation. I don't know whether all of you have also made this observation. I realized that among the very young, especially the ladies, 20, you know, about age of 25 and so on, they present very, very high blood pressure at the clinic. Sometimes 240, you know, or 140. And I've observed that most of them, they bleach themselves. I don't know, but you know, and if they bleach themselves, they will deny it, but there's a telltale sign on their hands, you know, where you see a contrasting pigment, you know, and so on. And it's going to be very worrying because I see a large percentage of them with this very, very high blood pressure, 240 over 140 sometimes. You measure it 3 times and you doubt it. And if we are not careful, in 10 or 20 years' time, we are going to have, you know, very troublesome EPs. The only reason why they are not ending up with stroke and so on is because they are very young, so their cardiovascular system is versatile to such a very, very high blood pressure. But I would say 8 out of 10 of such people they have bleached themselves. So as general practitioners of family medicine, we have to look at this. And even in the males who come there, they also have noticed a couple of them with very high blood pressure. This is worth, you know, noticing.
Thank you very much. I think you mentioned resistant hypertension.
Yeah.
I'm not going to go into that, but the little I'll say is that when you say resistant hypertension, you should make sure that it's indeed resistant hypertension. I had a patient whose BP was persistently in the 200s and well above hundreds. And she was on all kinds of medications. So the daughter is a midwife. So she came to me one time and I said, wow, I looked at the drugs and I wasn't happy. I didn't think the drugs were reliable, they were normal antihypertensives. So what I did was that I put her on the same drugs, but on a certain specific medication, also expensive, but those are the drugs I would call branded generic. The next time the patient came to, the BP was 120/80. When my nurse told me, I didn't believe it. I checked it myself, and it was so. And it stayed like that till eventually she passed from whatever. So when we say resistant hypertension, a number of factors have to go in. We should look at the kind of medication the patient is taking, whether they are compliant in the first place. Right.
Thank you very much, everybody who came around to make this a success. We thank our father who has joined us, and I think the advice that is given, and especially for the young, patients that we have, we need to educate them. It's true, we are finding a number of those ones, and we are primary physicians, we are family physicians. We need to educate our clients. We need to, as we do media engagement in the next few weeks, we need to be talking about some of these things and educate them. I'm sure, my brother is also concerned about the measuring. We need to educate our clients. Checking BP is just not putting something there and checking. We need to find a way of educating them so that the right things are done. Dr. Stodazi, Dr. Setnani, and my team from Symbiotica, we are grateful to you. Our audience, today we had over 700 people joining in. Those who came in and out, probably over 800. We really appreciate you staying on to this time. I think that is a very educative one. The aim is to make sure that our clients out there get the best from us and we make the nation a very healthy nation. We really appreciate you. We want to say thank you to everybody and to let everybody know that we are just starting. Next week, we have a very interesting one in terms of the current management of diabetes. We're going to have a panel discussion. We're going to have our own Prof. Waima on, Dr. Jakum, a wonderful interventionist, cardiologist coming on, Dr. Finn in cancer, CDR. Soldier Woman is also coming on. We're going to learn when to initiate insulin as well. On that, make a time with that. These are the things that are driving the cardiovascular mortalities in the environment, and we need to learn, know it, and help our clients more. The following week, we'll be having, current management in primary headaches. These days, everybody goes there with headaches, and it's typhoid. Everybody goes in with headaches, and it's something else. We need to learn how to manage primary headaches. What are primary headaches? What are secondary headaches? When do we pick them up? So we'll be having that one as well. Neurologist, Dr. Clover will be with us, and our own sister, Dr. Baba Damoa, a family physician, senior specialist, will also be with us. A week after, we're going to have a panel discussion, stakeholder engagement, with the directors of Ghana Health Service, looking at the network of practice where family physicians have a place there to make sure that we're supervising well. So that one will come on. And from the 16th to the 19th, we are going to Koforidua to wrap up our AGSM. Before that, we'll be having a big outreach in the Eastern region. Normally, we have over 1,000 people coming in. So every family physician should make time so that you join us there. It's not my outreach, it is our outreach. So let's make time, let's go and give to the society. And by this, I'm inviting every primary physician, every family physician to join us in all these programs, especially our AGSM that is going to be in Koforidua. Join us, it's going to be a wonderful time. We're going to learn a lot. There's going to be a scientific section where we're going to learn about collaborative research. We have our people all over the country. We'll need to learn how to do research collaboratively, multi-center research. It's going to be a wonderful one. We invite everybody to join us even as we go through this journey. On this note, I want to say thank you for everybody who joined us in person and all those who joined us online. Same time, Friday next week, we'll be having our next section. Thank you very much. Have a nice evening. We want to call on Elder again to give us the closing prayer.